Assalamu alaikum ji, and good morning everybody. I would like to welcome you all to the Shaukat Khanum Cancer Symposium, which is an annual event, and I would like to welcome you, and I'm very much thankful to all of you for joining us in this educational activity, which is an annual event which is held and hosted by Shaukat Khanum Hospital. We are going to take off our session with thoracic oncology this time. We all know that the paradigm of lung cancer treatment has evolved rapidly over past few years. Some breathtaking developments and monumental advances have been made in diagnostic and therapeutics in lung cancer. I am your moderator for the session, Dr. Tabinda Sadaf, and I have with me joined by my co-host and my co-moderator, Dr. Fatehullah Khan, who is a respiratory medicine consultant joining us from Shaukat Khanum Hospital, Peshawar. Welcome, Dr. Fatehullah Khan.
Hello, thank you.
In our session, we have 4 talks lined up covering all multidisciplinary aspects of the lung cancer treatment, from treatment, diagnosis to treatment, and advances in management of non-small cell lung cancer, small cell lung cancer, including systemic treatment and radiotherapy developments. I would like to hand over to Dr. Fatehullah Khan to formally inaugurate the session now and start introduce our first speaker.
Okay, thank you, Dr. Tabinda. I welcome you all on behalf of Shaukat Khanum Cancer Hospital for this esteemed symposium. Our first speaker is Dr. Tufail, Muhammad Tufail, who is a consultant respiratory physician in Glenfield Hospital in Leicester. I know him as one of my mentors and brothers. He is head of lung cancer services at Glenfield Hospital in the UK. He has got special interest in pleural disease and interventional pulmonology, and he specializes in EBUS, medical thoracoscopies and cryobiopsies, and he's an excellent trainer. He is going to present on how to optimize multidisciplinary approach in lung cancer. So, start please. Hassan, first.
Good morning. I'm very much grateful to the organizers of this prestigious symposium for your kind invitation to talk about optimization of multidisciplinary approach to management of lung cancer. So I'm a consultant chest physician in Leicester, UK. I'm the lead for lung cancer services there. In next few slides, I would like to outline the structure of lung cancer services in the UK and what we have done in last few years to optimize these services further and achieve better outcomes for our patients. Just to briefly inform you about National Health Service, or NHS, that it is based on the principle that good healthcare is made available to all regardless of their wealth, and treatment is available free at the point of delivery. So it does come at the cost of about 120 billion pounds per annum. This is not to say the same model I will talk about applies to all healthcare systems, as different healthcare systems work on different models. So lung cancer accounts for 13% of all cancer diagnoses, and it is the deadliest cancer and is responsible for 25% of all cancer deaths worldwide. So globally, nearly 2 million people die of lung cancer each year, and the true consequences of tobacco epidemic are yet to come. This is an important headline from BBC, where they are mentioning about 10 top causes of death in the UK, and COVID has remained at the top 10 causes of death. But you can see that in January 2021, COVID was very much responsible for many deaths, but thanks to our successful vaccination program, that by July 2021, that rate due to COVID has significantly reduced. But if you concentrate on light green bar, that is for lung cancer, and lung cancer is the only cancer which has made the headlines to the top 10 causes of death. No, we had vaccine for COVID, and we have reduced the mortality due to COVID quickly, but there is no vaccine for lung cancer. We need to understand the true burden of lung cancer and need to do something to reduce this burden for our patients and our healthcare systems. So why do we need faster and well-coordinated lung cancer pathways? There is a proper reason for that. And this slide I have taken from TNM8 lung cancer staging, and understandably, as the lung cancer progresses or there is upstaging of the lung cancer, there's a reduced 5-year survival. And I would like to highlight stage 1A disease, which is now further divided into 1A1, 1A2, and 1A3 stage, and that depends upon the size of the lesion. Let's say the size of the lesion is less than 10 millimeter, and it is 1A1 disease, the 5-year survival is 92%. Now the same lesion grows by few millimeter and it becomes T1B, the survival, 5-year survival goes down to 83%. So that is a 9% reduction in 5-year survival by growth of the lesion by few millimeter. So I would like to highlight here that the millimeters matter when it comes to lung cancer. And if millimeters matter, then the speed of the pathway matters. And there's a wealth of data and publication around to show about timeliness of lung cancer pathways and improved outcomes. The lung cancer outcomes have not been great in the UK. So NHS brought up this national optimal lung cancer pathway over the last few years, just to highlight that in the UK, whenever there is a suspicion of any cancer and patient is referred to us, we have to see that patient within 2 weeks. All the investigation process has to be completed within 31 days and treatment has to be initiated within 62 days. And we are subject to national lung cancer audit, and data for all the hospitals is published every year. Through national optimal lung cancer pathway, we want to complete the diagnostic process by day 28 and all treatment started by day 49. So we have implemented a few pathways in Leicester, and our main pathway is direct to CT pathway, which means a patient has undergone a chest X-ray in the community for any reason. So family physician has referred the patient for cough, shortness of breath, chest pain, and patient undergoes a chest X-ray in the hospital or in the community hubs. If there is any suspicion of cancer on the chest X-ray, we will take the full ownership of the patient. The radiology department will invite the patient within 3 working days to undergo a CT scan of the chest to investigate it further. Here, the general practitioner does not have to do much really. So when the patient attends for CT scan, the patient is greeted by one of our lung cancer specialist nurse who take brief history and assess the performance status and comorbidities of the patient. And these CT scans are reported on the same day or within 24 hours. And once these are reported, they are discussed in our triage meetings, and we make further diagnostic and management plans from there on, so without wasting any time. So we think this leads to faster diagnosis and better outcomes. I would like to explain it with one example. This is a patient who is one of our first patients in the optimal pathway as we implemented in January 2019. So patient undergoes a chest X-ray on 1st of March 2019 for left-sided chest pain, and patient is referred by a general practitioner. And you can clearly see the chest X-ray is abnormal, and a subsequent CT scan few days later not only showed lung cancer, but also spinal cord compression. No, the lung cancer specialist nurse had met the patient at the time of CT scan, and patient mentioned about feeling weak in the legs over the last few days, and patient was actually brought to the radiology department in a wheelchair. She suspected the diagnosis of lung cancer. She alerted the consultant radiologist, who reported the CT scan immediately, and there was a confirmation of spinal cord compression. So we directly admitted the patient from radiology department to our acute admission unit, and palliative radiotherapy was given to this patient next day. So you can imagine, had this patient gone home after undergoing CT scan of the chest, she could have presented later on to our emergency department with paraplegia and urinary incontinence, and it could have been a disaster for the patient. So our triage meetings are the cornerstones of our pathway, which are attended by a lung cancer consultant, a fellow, and a lung cancer nurse, and a next step coordinator, where we discuss all the CT scans performed and do all the diagnostic planning from there. So once we have seen the CT scan report, we will decide what investigation is the best for the patient, and we will have all the information about performance status and comorbidities, etc., from our lung cancer nurse. Obviously, the patients are referred from other routes as well, from family physicians directly, and from within the hospital, from other specialties, or if there is a referral for EBUS or bronchoscopy, we will discuss them and take all the actions from there. So these triage meetings are the hubs to make diagnostic planning for our patients. So obviously, we do invite the patients to come to our clinics to inform them about diagnostic process and our suspicion of cancer. Another intervention is about optimization of our multidisciplinary team meetings. Our multidisciplinary team meetings takes place only once a week on Friday morning, and we discuss up to about 50 patients there. And these MDTs are therapeutic management MDTs, i.e. we don't discuss patients just to do a diagnostic planning in these MDTs. And you can imagine that we don't need oncologist or pathologist or palliative care consultant to decide whether we are going to do FNA of the neck or bronchoscopy or EBUS. I mean, this is all done in the triage meetings. So our lung cancer MDT is mainly a therapeutic management plans MDT, and as the lead of lung cancer services, I'm the gatekeeper for this, and I will make sure that only appropriate patients are listed for our MDT discussion. Another important pathway we implemented is the alert system for our small cell lung cancer pathway. So as you all know, small cell lung cancer is one of the most aggressive cancers, and it is very sensitive to chemotherapy, but patients do deteriorate within days. And if urgent action is not taken, we may have missed the boat, and the patient may not be eligible anymore to undergo any treatment. So previously, these patients did not go any treatment until MDT had decided, which takes place only once a week. So we implemented the alert system whereby whenever there is a diagnosis of small cell, our pathologist will immediately send an email to myself, to medical oncology team, to our lung cancer specialists to tell us any day of the week that it is a small cell lung cancer diagnosis. We will bring the patient to clinic same day or next day and initiate the management plan immediately. So patients don't have to wait for MDT to decide that they are going to have treatment. We are hands-on and work on this pathway every day of the week. I would like to highlight this further, that this is a patient who underwent CT scan of the chest on 28th of January 2019. As you can see on the CT scan, there is a perihilar lesion, significant mediastinal lymphadenopathy, and the radiologist had sent an alert that this could be possibly small cell lung cancer, and we managed to list the patient for endobronchial ultrasound next day and send the samples to pathologist urgently, mentioning that this could be small cell, and it was reported as small cell. A couple of days later, alert was sent, and we managed to get the patient admitted for initiation of treatment. And you can see it did not take many days for the diagnostic and investigation process. Had we done delays, this patient may not have been very fit to undergo any treatment. This is another example. This patient was referred for shoulder pain actually, and for shoulder X-ray. And on the shoulder X-ray, you can see there is an abnormal right hilar area. So patient was invited to undergo a chest X-ray and then subsequently CT scan. And at the time of CT scan, it was reported as a pencast tumor. and the lung cancer specialist nurse got the patient into triage meeting with the full report, and we saw the patient in our cancer clinic on the same day, and there was a neck node palpable. We did the FNA of the neck node on 12th of March, and a couple of days later, our pathologist sent an alert that this FNA confirmed small cell lung cancer. Without wasting any time, we got the patient in and started chemotherapy next day. So that's how our small cell pathway works. We have not spent millions of pounds on this one. It is just to be proactive for our patients, just to implement an alert system where radiologists, pathologists, and medical oncologists all are alert to any diagnosis of small cell lung cancer so that we can take immediate actions. We have analyzed our data. So this pathway was implemented in August 2018. So data 1 year before and 1 year after the implementation of this alert system, you can see that there is reduction from median referral to biopsy days, from median referral to diagnosis, and from diagnosis to treatment days. So everything has speeded up through this alert system. And this is all due to improved communication among the teams. And we further looked into it that by implementing this alert system and being very proactive for our patients, the 30-day mortality for small cell lung cancer in our unit halved within a year. And this is a great contribution from a great team, I will say. I would like to spend a few minutes about emergency presentations of lung cancer. Unfortunately, a significant proportion of lung cancer patients are first diagnosed when they present as an emergency to acute medical services with spinal cord compression, SVCO, hyponatremia, brain metastases, as you all know. And this creates a lot of burden for the healthcare systems. If patients are diagnosed through emergency route, they are less likely to receive any anti-cancer treatments as compared to the patients who are diagnosed through elective route. And emergency route of presentation is clearly a negative predictor for survival and associated with increased healthcare costs. So throughout the UK, 35% of the lung cancer diagnoses are made through emergency presentation, which is a significant number. And in our trust, this number was 27% in 2018. So after the implementation of optimal lung cancer pathway, you can see the patients diagnosed through emergency route have gone down. So in 2018, 27% patients were diagnosed by emergency route, and after the implementation of optimal lung cancer pathway, this number went down to 18%. So we have shown that there is a 32% relative reduction in emergency presentations of lung cancer through implementation of all these pathways. I think this is significant. We don't want the patients to present as an emergency when they are first diagnosed with lung cancer. We want to pick up our patients as early as possible. And we have also shown the cost effectiveness of this pathway. And these are our figures. Implemented patient satisfaction survey. So we surveyed 152 patients to tell us about the quality of our services. And as you can see, majority of our patients rated our services excellent to good. And these are some of the comments from some patients. And this is a great attribute to our team. And every member of the team is important here to get these good outcomes and better satisfaction of the patient. And this is only possible through a great teamwork. So in summary, I remain very optimistic that in coming years, through lung cancer screening programs, early detections, biomarkers, and immunotherapies, and we have got many lung cancer mutations against which we have got targeted treatments. AI is coming. So the outlook remains good, but we still need to do a lot to improve the morbidity and mortality associated with lung cancer. And I hope that in last 20 minutes or so, I have been able to prove the association of timeliness with better outcomes and better patient satisfaction. And that is very important. And this is only possible through great teamwork and through cohesiveness. And I'm very much thankful to my team. And I'm also grateful to you all for listening to me. Thank you very much.
Thank you very much, Dr. Tufail. This was an excellent talk. And I hope we could learn and simulate this pathway somehow in Pakistan as well. I'm going to introduce my second speaker. I have the honor and privilege to train under Professor John Bennett in Glenfield. Dr. John Bennett is a consultant respiratory physician at Glenfield Hospital, which is a very prestigious hospital in the UK for respiratory medicine. He is an avid sportsman and has keen interest in cycling and football, and he is a very ardent Wolves supporter. He's expert in bronchoscopy and trainer of bronchoscopy and EBUS. He's going to present his talk highlighting the optimal lung cancer pathway and diagnostics.
So, Mohammed, many thanks for taking us through the Leicester optimal lung cancer pathway. I thought I'd just add a little bit more in terms of how that impacts in terms of individual patients by taking us through 3 case histories. I'd like to thank Shaukat Memorial Hospital and Research Centre for inviting me. It's a great honour and privilege to talk to colleagues in Pakistan, and especially to Fatullah, who I know very well from our time together at Leicester. What I'd like to have is some idea for you in terms of how the implementation of the optimal lung cancer pathways improved treatment from case studies, and also to discuss a couple of dilemmas that we have along the way in terms of it being from a multidisciplinary team approach. So the first case is a patient that was reviewed by our nurses at the time of CT scan. As you can see, she's a 46-year-old lady with a 6-month history of cough. And it was cough with pure hemoptysis, not spitting out blood, not blowing a nose and having blood, but coughing up blood. She'd had 3 courses of antibiotics with no improvement in terms of her symptoms, which also included progressive breathlessness and wheeze. And all of these cases, including this one, is at the time of COVID, where obviously face-to-face consultations have been very different, and there's lots of telephone consultations or video consultations going on. She has a smoking history as an ex-smoker of a year. Not surprisingly, we did a chest x-ray. The chest x-ray was normal. From our perspective, for people with a convincing story of hemoptysis, our optimal lung cancer pathway states that we should do a CT chest. And I think that this was appropriate, and I hopefully we'll be able to demonstrate this with this case. Here's the relevant slide, the slice for our patient. Nothing in the lungs, but a significant posterior wall tracheal lesion. That was unexpected for her and obviously unexpected for us. So given that, we decided that we needed to do more tests, and we reviewed her in the optimal lung cancer pathway triage meeting that you've been hearing about previously. We took the information that the nurses had from her, we took the information from the CT scan, and we decided that we needed to move on with having more tests booked, which the nurses could let her know about without us actually having to see her. So lung function tests and a PET scan. And we felt that we needed to see with the results of these. We were considering bronchoscopy, and we'll talk a little bit more about that in a couple of minutes. The PET scan confirmed the CT findings. A tracheal lesion on the posterior wall, levels T2 to T3. No other lesions seen anywhere else. Our spirometry showed flattened expiratory flow volume loop, consistent with large airway obstruction, so a markedly reduced peak expiratory flow compared to our FEV1. As you can see that the ratio here is 10.8. So we're left with a lady that has large airway partial obstruction from an isolated tracheal lesion on the posterior wall, level T2 to T3. And we reviewed her with the results of all these tests in clinic. At the time of review, I'd already contacted our thoracic surgical colleagues about her, and they arranged to see her, as I said that I would prefer for her to have a rigid bronchoscopy with potential for laser tumor debulking, if depending upon what they saw. And they did this, and as you can see, they did laser debulk the tumor, and it was features in keeping with a low-grade mucoepidermoid carcinoma. So what we have here is somebody with hemoptysis, from referral from the GP to having a definitive treatment during the COVID-19 pandemic, was less than 28 days. And I'd hope that this demonstrated the MDT working between our nursing colleagues, our radiology colleagues, myself and Mohammed and the rest of the team in terms of respiratory physicians, and also our thoracic surgical colleagues.
That's a great case. Thank you, John. And I know you are a great bronchoscopist, and thank you for teaching us this skill as well. My question is, why did you go for the rigid bronchoscopy while you can do flexible bronchoscopy under sedation yourself?
Thank you, Mohammed. I did wonder about that, but I've always found tracheal lesions to be challenging in terms of flexible bronchoscopy. My worry is that the trachea is a single tube. And if I have significant bleeding or anything else, then with a flexible bronchoscope, I don't have control of the airway. I don't have a large suction port, 2.3 millimeters. And so it's easy to lose control of the airway. It's easy to lose vision. And it's easy if with a relatively small amount of bleeding and a 50% partial obstruction of the trachea to lose the airway, and therefore for patients to become significantly hypoxemic, peri-arrest, or even arrest from occlusion of the trachea. And if I can give an anecdote, one of my abiding memories as a trainee was to work with a very experienced bronchoscopist who biopsied an area of post-radiotherapy scarring for query recurrence in the trachea. And before we knew it, within 20 or 30 seconds, there was profuse hemorrhage. The patient was desaturating. We couldn't get control of the airway. The suction only allowed us to get so much. I was sent off to go next door to ITU to find an anaesthetist. The anaesthetist came. By this time, the anaesthetist arrived. The patient was peri-arrest. The anaesthetist intubated the patient semi-erect, semi-conscious, and thankfully managed with the ET tube and the cuff to tamponade the bleeding point to save the patient. But that's not an experience that I want to go through again, and it's not an experience I want any patient to go through either. And I just think with a large lesion with single airway that we should be thinking about rigid bronchoscopy, where you've got control of the airway, you've got a large suction port, and therefore we can actually control any complications that arise. And then the other thing is that we can actually do a more definitive procedure in terms of removing what might be an adenomatoid polyp, but in this case was a mucoepidermoid tumor. So I think that is a good learning point, and thank you for asking me that question, Mohammed. So if I move on to, actually, we weren't expecting this, and we weren't expecting it to be mucoepidermoid either. But as you can see, primary salivary gland tumors do occur in the lung. They do occur in the trachea. Tracheal tumors are uncommon. And the most common one is a squamous cell carcinoma. But the second most common are salivary gland tumors, which would include adenoid cystic carcinoma also. Should we resect the tracheal rings involved, or should we observe? Our patient's got a relatively low-grade mucoepidermoid tumor, and we've gone for a monitoring approach with repeat bronchoscopy. It may be that with ongoing recurrence that we will have to resect the tracheal rings, but as we all know, tracheal ring resection is not without its own hazards. So for our patient, we've elected for ongoing monitoring. If I could move to our second case. This was a man that again was seen on the cancer 2-week wait pathway. Within the 2 weeks of the referral, the patient was deteriorating rapidly. So at the time of the straight to see, or the CT, when he was seen by the nurses, he was noted to have increased confusion, malaise, lethargy, anorexia and weight loss, which was profound. He went from being completely independent to now being quite ill within 3 weeks. He had a 40-pack-a-year smoking history, and he was an ex-smoker of 5 years. And as you can see, he has central tumor. There's something happening in the center. There's widened mediastinum, and there's some changes in the left upper lobe as well. And he was seen by the nurses at the time of the CT who gave us this story. The family also weren't coping with him at home. So going from being completely independent to now being this unwell. The radiologist reported that the CT was grossly abnormal with significant mediastinal lymphadenopathy as seen here. The nurses contacted us directly and we arranged for him to be admitted to hospital. We felt that we needed to crack on and get him sorted. Otherwise, the window of opportunity for treatment for him was going to be lost and he was going to be dead soon. The CT stage, not unsurprisingly, was T4N3M1A. Again, you probably won't be surprised to know that his sodium was low. This raised for us the possibility of SIADH. We felt it was likely to be small cell carcinoma, both from his rapid deterioration, from his CT findings, and also from his blood findings, hyponatremia, SIADH. We gave him standard treatment. We fluid restricted him. We gave him dimethylcycline. There's obviously consideration of tolvaptan for some patients. He was already on the small cell cancer alert, which you've already heard about. He had no supraclavicular node, so we arranged for him to have an urgent E-bus to do TBNA. And with that, we alerted pathology, medical oncology, and transferred the samples to pathology by hand so that the pathologist could get on and actually review the samples.
That's an example of a great teamwork, John. I think, and I can see that right from beginning, from the time of CT scan, the team has been suspecting this patient to have small cell lung cancer. So I have two questions. What were the features which made you think that it is small cell, right, starting from radiology? And how did the alert system work throughout exactly?
So I think it was the fact that the nursing team realized that he had a rapid deterioration. So within 14 to 21 days, he went from being completely independent to being almost completely dependent. That's not a good sign. That often fits with the rapid deterioration seen with small cell. The radiologists, because they managed to do the timely reporting so that the report was available to the nursing team or to us at the point at which the patient hadn't left the building, meant also with the nursing team being able to alert us and the radiology team alerting us to say that this is bad disease, is that we immediately thought that this was small cell. With that, we then persuaded the patient via the nursing team to come into hospital. That was the part of the small cell pathway. We then also alerted the endoscopy team, can we get this person on to have a sampling quickly? And the pathologist team, can you be aware that this person is likely to have small cell? And again, we let the medical oncology team know. Not everybody in this situation has small cell lung cancer, and some of them do have non-small cell lung cancer. But for those that have small cell lung cancer, it genuinely is a matter of hours to days, can be critical. The window of opportunity for treatment for him was, I think, days. A few more days later, and he'd have lost that window of opportunity, and he would have been dead within probably 14 to 21 days. So thank you for that. So we essentially treated him within 72 hours of being alerted at the time of seeing him in the CT scanner. And for us, MDT registration is not about planning the treatment. The outcome and the treatment pathway was obvious. You don't need to have 10 people deciding the treatment pathway. It was obvious what the treatment pathway needed to be, or the diagnostic pathway. We just need to crack on, do it, and then register it afterwards. Moving on to the last case, if I may, this is, as you see, a 50-year-old man, relatively young man, younger than me, so that always makes me worried. Gained cancer 2-week wait from the GP. He'd had a cough for several months. Again, that's very common, especially now in the COVID environment. Facial swelling for 2 weeks, general malaise for 4 weeks, and he was a current smoker. And again, we can see that he has central tumor. The mediastinum has widened, the right hilum just looks bulky and abnormal. And when he was seen, he had symptoms and features which would be consistent with SVC obstruction. And he had a large central right hilum mass with mediastinal invasion. So the CT stage was T4N2M0. And again, the nursing team were alerted us in the triage meeting that they had somebody in front of them who looked to have SVC obstruction, had symptoms consistent with that. The radiology team also were able to get the report up to us so that we could feed back to the nurses that this man needed to come in. We needed to again crack on and sort him out. It appeared, though, that the lesion T4N2M0, he's young, he's fit, was localized. So could there be a potential for radical treatment? With this in mind, we arranged for him to have a PET scan, but because the PET doesn't cover the brain so well, we also arranged for him to have an urgent MR brain. And as you can see here, there's evidence that up to 11% of patients with advanced stage 3 lung cancer may have an asymptomatic brain metastases. And knowing this would obviously change the treatment intent. If we had a favorable PET scan, but an unfavorable MRI brain, we wouldn't be doing mostly radical treatment. So the PET scan, as you can see here, shows that he did have localized central tumor. It confirmed T4N2M0, no other distant metastases. The MRA brain thankfully showed no occult metastases. So this fitted with our presumptive and our hopeful management plan of concurrent chemoradiotherapy. And I suppose then the question is, how do we manage his SVCO?
Thank you, John. I think I had seen this patient in clinic. I remember that patient is very symptomatic with SVCO symptoms. And you know, from our clinic, patients leave with the next steps in their management plan so that they are well aware of what is happening with them. So I called the vascular intervention radiologist to ask for a stent insertion in SVC, but they quoted a mortality rate of 2% and significant potential complication. They asked me to speak to oncologists if they can start chemoradiotherapy. And I spoke to the oncologist, and they said, oh, it may take a couple of weeks to see the effects of chemoradiotherapy. You should go back to vascular interventional radiologist to have stent first. So how do you decide what should be the next best step for this patient? Whether we should go for a stent first or we should go for chemoradiotherapy?
So I think this partly depends upon the tissue type, and the way I very simply divide it up is non-small cell and small cell. And non-small cell, essentially, it takes longer for the chemoradiotherapy to work, and SVC obstruction can be critical in terms of patient, not only symptoms, but in terms of their prognosis. Patients with ongoing SVC obstruction have a worse outcome. And because it takes longer for the chemoradiotherapy to work in patients with non-small cell lung cancer, I would always encourage our interventional vascular radiologist to insert a stent. And that's what we did in this case. And the patient's symptoms were relieved within minutes of the stent going in. And the worry is obviously that the stent might migrate. The main concern is if you shrink down the primary lesion, does the stent then move from where it's sited? But with non-small cell lung cancer taking a while, and with chemoradiotherapy being associated with some stenosis and fibrosis in that area, it's most unusual for stent migration. However, with small cell lung cancer, which is much more chemoradiosensitive, as we all know, it may be that chemoradiotherapy makes a significant difference within hours to days in terms of the SVC obstruction. And so therefore the risk of stent migration is so much higher. And that applies also to tracheal or bronchial stenting, is that with small cell lung cancer, I may not have demonstrated that millimeters matters because some of these patients had more than millimeters, certainly centimeters. But the straight to CT following chest X-ray, we found extremely beneficial. Our nurses are now extremely skilled at assessing patients, and the contact that we have in terms of the interaction with radiology, nurses, and doing virtual review of patient history and imaging does enable us to get on and do things quickly. So that also minimizes hospital attendance for patients. What we don't want, especially in a COVID environment, is to have lots of patients having to come up to a hospital environment, which may not be quite so safe for them. The bundling of tests according to the provisional stage also enables us to be able to be rapid and to put the patient's best interests at heart. So for the last patient, as you saw, PET CT with MRI brain, getting the tissue sorted as quickly as possible and liaising with the team. It's always great to work within a great team. I'm really grateful that I can genuinely say that the team at Leicester is a fantastic team. And I'd like to also emphasize that I know that all respiratory teams, pretty much locally and nationally and internationally, are great teams, because that's the beauty of working in respiratory medicine, is such lovely people, both in terms of colleagues, but also in terms of patients. And with that, I'd like you to thank you for your time and wish you all the best for the rest of the conference. Thank you.
Thank you very much, Dr. Prof. Jonathan Bennett. It was a very wonderful talk. And we had some interactive session as well in between because of the questions that we had. Because in the interest of time, we'll move on to our next presenter and we'll have the discussion and question answers at the end of the session. I would like to introduce my next speaker, who's Dr. Hamza Al-Baba. He's a consultant medical oncologist at Jack Addy Cancer Center, Alberta, Canada. Dr. Hamza Al-Baba is a co-investigator in many of the clinical trials and has spearheaded many clinical research trials in Princess Margaret Hospital as well. So thank you very much, Dr. Hamza, for joining us at this hour in time and sharing your views and thoughts about about current and future directions in the management of non-small cell lung cancer therapy. So from diagnostics, we are moving on to the management part now by Dr. Hamza Al-Baba. Over to you now.
Assalamu alaikum, how are you? I hope you're doing well. Thank you everyone for inviting me to speak about lung cancer and this prestigious meeting. I thank the organizers and the attendee. Today we'll be talking about a new era of lung cancer. So let me please share my slides with you. For disclosure, I have no disclosures. As a background, as everyone knows, lung cancer is now the most common cancer if we talk about incidence in the developed countries. But also it's the leading cause of death all over the world. Over than 70% of a new patient diagnosed with lung cancer, usually they have advanced disease and they will be treated with palliative chemotherapy only and with no cure. Until a decade ago, treatment used to be only chemotherapy, it used to be single agent, then they start to talk about doublet. From last year, Canadian Cancer Statistics, they issued a special document on lung cancer, which showed that in Canada in 2020, it was expected that the death rate from lung cancer would outweigh the deaths from colorectal cancers, breast cancer, and pancreatic cancer combined. And that would give you an idea about the mortality rate of this cancer and how aggressive it is. If we go back to the year of 2002, when first they started to talk about platinum doublets, which they found that cisplatin with paclitaxel or gemcitabine or docetaxel or paclitaxel, and they have similar response rate, and that has improved the median overall survival around 8 months. But still, if you can look at the curves, they were combined, and there is no differences between these chemotherapy. Later on, in 2008, they started to test newer chemotherapy in lung cancer, and one of them was Pemetrexed. And they found out that Pemetrix was similar with cisplatin. Doublet was similar to cisplatin with gemcitabine, which is one of the standard lines at that point, but it has similar survival benefit, similar PFS rate, or progression-free rate with less toxicity, and it's gonna be it's given every 3 weeks instead of every week like gemcitabine. With sub-analysis, they found out for patients with non-sequem histology, I mean by that, if they have adenocarcinoma, large cell neuroendocrine carcinoma, or a not otherwise specified, and there is difference in survival benefit, and there is no difference in PFS, which means if you take out the group of patients with squamous cell carcinoma, Pemetrix would be the best choice, which has shown less side effects with some improvement in overall survival. I believe the overall survival will increase from 10.9 with cis and gemcitabine months to 12.6. If you look at the other group with squamous cell carcinoma, it's actually inferior, and it should not be used in squamous cancer. Later on, they tested the same chemotherapy metrics to the maintenance setting, and from there, the guidelines changed after they found there is significant improvement in progression-free survival as well as overall survival with significant hazard ratio. And from that point, we start to do platinum doublet for 4 cycles and instead of 6 cycles. And then after that, we continue with Pemetrix maintenance. After those years, they start to talk about TKI, but at the first study was in 2005 by Dr. Shepard, which is one of my mentors that I've been trained with in Ontario. In this study, they tested one of the first-line TKI, erlotinib, beyond first-line in non-small cell lung cancer. At that point, nobody knew that there was something called EGFR mutation, but we knew that there is something called EGFR amplification, which is very common in lung cancer and many other cancers. It's around 90% of patients. This study showed there's significant improvement in overall survival. The hazard ratio was 0.7. Progression-free survival improvement was 0.61 for all patients in that group. Later on, another study from Dr. Kim, but for another first-line TKI called gefitinib, it was compared versus docetaxel. The first study was, there was only a placebo in the other arm, but this study had chemotherapy. But unfortunately, this study showed no superiority of gefitinib over docetaxel on non-selected group of non-small cell lung cancer. And that raised the question why there was a response in some patients, but others showed no response. Then later on, Dr. Mock, who is one of the physicians that was trained also with Dr. Shepard in Ontario, and then went back to Hong Kong, he tested gefitinib, the first line TKI in the first line. And he tested that drug in the first line versus carboplatin paclitaxel in Asian patients. Most of them were non-smoker. And there was the surprise. The overall response rate was improved with good significant hazard ratio. But then they realized that some patients respond in a nicer way than other patients. So they tested those patients with response. And then that was the first time anybody would talk about EGFR mutation at that point. And they realized there is something called EGFR mutation and not amplification. And the response rate was significant with a very nice hazard ratio, has never been seen in lung cancer before that time for progression-free survival, as well as they looked at patients without a mutation. Actually, it was worse than chemotherapy with significant decrease in progression-free survival. So after that, gefitinib became a new drug that should be given to patients with EGFR mutation, which usually it's more common with adenocarcinoma of the lung, non-smokers, females, or Asian patients. After 2009, there was a new era for lung cancer research. As we can look at this diagram, it used to be non-small cell lung cancer only versus small cell lung cancer. After that, they had divided it to adenocarcinoma, which is the most common, 55%, squam, 35%, and others, which has been divided later on to large cell carcinoma and NOS, which are none otherwise specified. But now with the newer generation, you can look at adenocarcinoma alone. There's what the majority is KRAS mutation, which is 25%. This is one of the new things that happening at these days. Also, EGFR is the second most common. There is ALK, 70% of patients, but there is many others: MET mutation, HER2, ROS1, BRAF, RET, and TRAC, and BI, KIT-ACA. Those are a new mutation that has been found. If you look at these mutations, 97% of these mutations are mutually exclusive, which means if you could find EGFR, there is no way to find ALK. It's extremely rare. I cannot say never, because we have seen one or few cases, maybe less than 2 cases over the last 10 years. In 2021, if you look at each one of those mutations like EGFR, now we have at least 3 generations of TKI: gefitinib, erlotinib first generation, then afatinib was second generation, then osimertinib the third generation. Also, if you look at ALK inhibitor, crizotinib was the first generation, then alectinib, voxelotinib second generation, then lorlatinib and brigatinib. Also, for other mutation, now we have for the MET exon 14, cabmatinib with good response. We have for ROS1, crizotinib, and the entrectinib. For BRAF mutation, the V600, we have the brafenib, because now they divide them for BRAF V600E mutation versus non-V600E, because we have many of them. RET diffusion, also there is a new drugs for it, and TRAC, which we'll talk about them later. If we talk about EGFR in more details, as you know, EGFR mutation is common, about 15-20% in North America, but if you look at Asian populations, more up, it might be up 60%. And also in non-smokers patients, adenocarcinoma, it might be up to 50%. There is higher incidence in females, Asian, and smoker. And the most common EGFR mutation are exon 18 to 21. 90% of the EGFR mutations are either exon 19 or exon 21. And these mutations are the responsive one. We have some other mutations in exon 20, like exon 20 insertion, or the T790M mutation, which we call them resistant mutation, and some other mutations like exon 18, which they have less sensitive mutations. We had many studies in the first line setting with different first line and second line TKI. All of them showed significant improvement with good response rate versus chemo. And there is significant improvement in progression-free survival in all the studies, which resulted in significant hazard ratio. After the first line treatment, which usually used to be with either first line or second line EGFR inhibitors like erlotinib, afatinib in the second, so erlotinib in the first line and afatinib in the second line. And Memorial Sloan Kettering, they tested 155 patients with another biopsy after progression in the first line EGFR. And there was actually more than 60% of patients, they have T790M mutation, while others, they have a significant amount of small cell transformation, whether alone or with other resistant mutation. That opened the door for a new era of a new treatment. Also, HER2 mutation was there. And there was another a well-known study called the FLORA trial for osimertinib, which has been published in 2018, which showed that first-line osimertinib, if you compare it with the first or second generation, there is significant improvement in progression-free survival, and the curves start to be showing significant response like never before. And if you look at patients with CNS metastasis, there is a huge difference because patients that has been treated with EGFR first and second line inhibitor, most of the failure was in the brain because those drugs used not to penetrate the blood-brain barrier, but then with osimertinib, with good penetration to brain. So the progression-free survival was significant with good control for brain mets. Overall survival was improved. Then after that, they also tested patients who progressed after osimertinib. So after treatment with osimertinib, there is a newer mutation called C797S mutation. Sometimes it will be alone or with the same T790 mutation. There is many clinical trials trying to combine osimertinib with other MEK inhibitors to see if that would work. Also, small cell transformation is very important. You have to keep an eye if your cancer patient with lung cancer that he has been on one of the TKI, and you've noticed there is significant progression on one of those drugs. In a short period of time, do another biopsy, roll out small cell transformation. Also, HER2 amplification is common, MYT amplification is common. There is another new thing now is happening. They do liquid biopsies for patients who progressed on TKI. Usually we send blood for what we call liquid biopsies that check for tumor circulating cells. And mainly it has been done for T790 resistant mutation. But even if you did that, there is a good chance to pick up that mutation in the blood, but there's another 30% false negative results. So even if the result was negative, you have to do a biopsy. But if it's positive, you save your patient another biopsy. For the other arrangement, the ALK arrangement, as you know, it's more common in non-smokers. Non-sequem, it's around 4% of all non-small cell lung cancer, but in around 33% of EGR negative never smokers. There is also has been approved first-line crizotinib, which we don't use anymore because of poor penetration to brain. Now, ceritinib, alectinib, brigatinib, lorlatinib, all of them has been approved in the first line after they've shown a huge difference and superiority from crizotinib. If we talk about alectinib in the first line, it has been approved in 2017. And if you look at the progression-free survival, there is a significant hazard ratio. If you look at the alectinib versus crizotinib, also CNS progression, it was amazing. It could penetrate the brain, a blood-brain barrier with good control, which we have never seen with the crizotinib. Also, crizotinib, we used to see most of the progression in the brain. Overall survival was also significant. Another trial for lorlatinib, which has been published in 2020, showed significant response. We have never seen any curves like these in lung cancer before. If you look at the progression-free survival, the hazard ratio was 0.28. And for patients without CNS metastasis, was 0.07. That's a huge improvement. Also with patients with CNS progression, and look at the difference. It's very significant if you compare lorlatinib with the crizotinib. Overall survival has been improved too. Another drug, brigatinib, which has been approved in 2018. There is also significant difference in progression-free survival if you compare it to crizotinib. I think after this study, no one is using crizotinib anymore, unless there is a lot of contraindications for other drugs. Also, brigatinib has good CNS penetration and improvement. But with brigatinib, you have to watch out for pneumonitis. There is an increasing number of case report of pneumonitis with brigatinib. So if your patient, after you start the drug within a week or two, developed bilateral infiltrate, severe shortness of breath, keep it in your mind. Pneumonitis is one of the causes of brigatinib, one of the side effects of brigatinib. For ROS1, which is another target, crizotinib can be used. It has been tested in the Profile 1001 study as a subgroup, which showed significant improvement in the response rate. And you can look at patients with partial response as well as complete response. They are significant with crizotinib. Also, ceritinib has been tested in a phase 2 study, which showed significant improvement in progression-free survival for patients with ROS1 and lung cancer. We're going to shift gears to MYT mutation as well as the exon 14 skipping mutation because of time. As you know, MYT and MYT exon 14, they are normal role in embryogenesis and wound healing. In cancer, they found that the MYT exon 14 skipping mutation causes an frame deletion of juxtamembrane domain, resulting in increased stability of the cancer cell, which results in cancer growth. It's around 3 to 4% of non-squamous cell lung cancer. But if you look at patients with sarcomatoid cancer of the lung, it's very common, around 20 to 30%. And crizotinib has been tested in patients with MYT exon 14. There is some responses, but there is a lot of failure in the brain because this drug does not penetrate CNS. And if you look at the maximal inhibitory concentration for the drug crizotinib, they will need a lot of a drug concentration to reach the therapeutic dose in the brain, while other innumerable drugs, they need much less doses. So if we talk about capmatinib, which is one of the new drugs that are targeting MYT mutation or MYT exon 14, and there is significant improvement for patients that has been treated. In the second line, there's around 40% response rate, while patients in the first line, around 70% response rate. and most of the patients had response in their brain. Another study for tepotinib, another drug targeting same mutation, MET mutation, also showed significant duration of response around 11.1, progression-free survival 8.1, and patients with CNS response, they have also better response than crizotinib. If we talk about retifusion, we have also another tyrosine kinase inhibitor that target retin fusion. RET usually 1 to 2% of non-squamous non-small cell lung cancer. It's very common in papillary thyroid cancer, around 20%. We have 2 drugs approved for that already from phase 1 and phase 2 study. One of them called silvercatinib. The duration of response was 17.5 months, PFS 16.5 months, while the overall response rate was 85%. Which is very significant in patients with RET fusion positive. Another drug called the pralsetinib, the tumor reduction was 96% for patients who are treatment naive with a good duration of response, which was not reached in this study. Also, if you look at those inhibitors, they have good penetration to brain with significant responses. Shift gears to HER2 mutation, whether insertion or deletion. 90% of HER2 mutation usually in exon 20. There is many trials has been tested, testing different drugs with different combinations without a huge response until recently. If you look here, this drug has been tested, bosutinib. It has some side effects, which is serious, but the response rate is 50%. This drug also has been tested with significant response rate. If you look at HER2 mutation insertion, another a new trastuzumab drug has been tested with good response. If you look at this study called the Chrysalis for amivantamab, it's one of the newer drug targeting exon 20. It's now still a phase 1 study, but if you look at the response rate, around 40%, which is very good, and the cancer, and the clinical benefit ratio was around 75%. 3/4 of patients, they had good control of their cancer. If we talk about the other new target right now, KRAS mutation. As we know, KRAS mutation is around 25% of all lung cancer patients, but KRAS G12C specifically is around 13% of those cancer patients. There's a few drugs now has been tested, but this drug has shown significant response with almost disease control rate 100%, while side effects are very minimal. Now it has moved to phase 2 study, and the name of the drug is sotorasib. There is a very nice response and good penetration to brain. If you look at the disease control rate is around 80% from FIN and tracking mutation, you can use one of those drugs, which has been proven to be effective with a response rate around 60%. Even they have good penetration to brain with good control rate. I don't think we have enough time in those 20 minutes to talk about immunotherapy in lung cancer, but just in general to know, we usually test lung cancer for PD-L1 if it's low negative, so it has to be used with chemotherapy, whether sequem or non-sequem histology. If it's also low positive, you need to use it with chemotherapy. But if PD-L1 is high, more than 50%, it can be used alone or with chemotherapy. There is many trials, many different combinations of PD-1 inhibitors or PD-L1 inhibitors, and there is a lot of studies that need another lecture or two about it alone. And there's a lot of improvement in immunotherapy over the last few years, from 2015 to 2021. And if you look at this curve now, we have many mutations with many targetable drugs, which has changed the game of lung cancer. And thank you for your attending this conference. And if you have any question, you can email me on my email. Thank you.
Thank you very much, Dr. Hamza. This was a wonderful talk. It's such a wide and subject which you tried to cover in 20 minutes. And I know the time was not in your favor, but you just tried your best to cover all the aspects of non-small cell lung cancer in 20 minutes. We'll have question and answers at the end, and even the audience can type their questions in the chat and we will reply them as far as we can. So moving on to our next talk, we have Dr. Nouman Ashraf. He's a consultant medical oncologist. He's joining us from Florida, USA, and he'll be talking about advances in small cell lung cancer. So Dr. Nouman Ashraf, over to you now.
Assalamu alaikum, everyone. I'm very excited to present recent advances in small cell lung cancer. I have no financial disclosures. We'll be talking about some updates in small cell lung cancer, some things that happened in 2021 with respect to immunotherapy, chemotherapy, targeted therapy, some supportive care drugs that were approved, radiotherapy, and then more excitingly, we'll be talking about the future of small cell lung cancer. So as you may know, a lot of drugs have been recently approved in non-small cell lung cancer. However, unfortunately, not much has changed in small cell lung cancer. And if anything, we've lost approvals for some of the immune checkpoint inhibitors in 2021. And we'll talk about these in more detail in just a couple of minutes. As far as immunotherapy, back in 2018, nivolumab was approved in third line and beyond setting, and the other checkpoint inhibitor, pembrolizumab, was approved in 2019. Both these approvals were based on small studies. For example, the nivolumab on the CheckMate 32 and pembrolizumab on 2 keynote trials. As you may recall, the CheckMate 32 trial enrolled patients who had failed platinum. They could have received other chemotherapy after that into 3 arms: nivolumab, ipi-nivo with a lower dose of ipi, or ipi-nivo at a higher dose of ipi with the 3 milligrams per kilogram. And the primary endpoint was overall response rate. As you can see, the response rates were about 10% in nivolumab single agent and close to 19% with lower dose ipi along with nivo, slightly higher, 23%. Based on these, and actually, if you look at the data, I mean, based on these results, the FDA provided accelerated approval to nivolumab in 2018. This year, we had 2 CheckMate trials, which were both negative trials. The first one was a CheckMate 331. And in this trial, the patients who had failed platinum were randomized to either single agent nivolumab or standard chemotherapy. Now, this chemotherapy in most countries was topotecan, although in Japan, they have amrubicin. Patients could be randomized to that. If you look at the numbers, over 500 patients were randomized 1-to-1 on this trial, and the key endpoint was overall survival. Unfortunately, there was no improvement in overall survival with nivolumab or even in the progression-free survival. The other trial, or sorry, before going on to the other trial, the overall response rate was slightly less in the nivo arm. However, patients, as you can see right here, patients who were responding, they had a long duration of response. Grade 3 toxicity was obviously less with the immunotherapy compared to chemotherapy. The other trial was the CheckMate 451 trial. This was a maintenance trial. Patients who were responding to etoposide platinum were randomized to either ipi-nivo maintenance followed by nivo or placebo. And over 800 patients were enrolled, and this trial was also published this year. Again, primary endpoint was overall survival with ipi-nivo compared to placebo. And this was a negative trial as well, whether you compared ipi-nivo to placebo or you compared nivo single agent to placebo. Both were negative for improvement in overall survival. Based on these 2 studies, the company has withdrawn its indication for third line setting and beyond an extensive stage small cell for nivolumab. As far as pembrolizumab, it was approved in 2019 for the same indication in the third line and beyond settings. This year, we learned about the CheckMate 604 trial, a large trial. Close to 450 patients on this trial were randomized. And the design of this trial was very similar to the Caspian or the Empower 133, I should say, where patients received platinum etoposide with or without pembrolizumab. And the primary endpoints, there were 2, progression-free survival and overall survival. The progression-free survival was better with pembrolizumab, and but the overall survival did not meet statistical significance. So the company actually withdrew its indication in March. You can see at 2 years, more patients were alive on the pembrolizumab. Nonetheless, this indication was taken away. As far as tremelimumab, it's a CTLA-4 antibody, and you may remember the Caspian trial where patients who were treatment naive were randomized to platinum etoposide with durvalumab, tremelimumab, or platinum etoposide, durvalumab, or platinum etoposide with placebo. And this trial led to the approval of durvalumab because it showed improvement in overall survival. And this is the updated results from Lancet Oncology this year, with a median overall survival 12.9 months compared to 10.5. However, in the arm receiving the tremelimumab durvalumab, there was no improvement in overall survival. Going on to chemotherapy, lurbinectedin is a drug that was approved last year for second-line setting after platinum failure, but this was, again, an accelerated approval. So when the FDA provides an accelerated approval, it's looking for more data for larger studies, such as a phase 3 trial, to look at the results. And the phase 3 trial for lurbinectedin was the Atlantis trial. In this trial, patients in the second line with extensive stage small cell were randomized to either doxorubicin lurbinectedin or other chemotherapy. That could be either topotecan or CAV, cyclophosphamide, adriamycin, vincristine. We do not have the actual results presented or published. However, the manufacturer in a press release said that it failed to meet the overall survival pre-specified endpoint. And we'll find out maybe later in World Lung Conference or later this year. Targeted therapy, a very promising approach was this ADC antibody drug conjugate ROVA-T against a ligand called delta-like ligand 3, which is expressed in over 80% of patients with small cell lung cancer. Now, ROVA-T is an antibody drug conjugate where it binds to DLL3, but also has a PBD, pyrrolobenzodiazepine toxin attached to it through a linker. Once endocytosed, the toxin is released and leads to cell death. So this is targeted therapy. Now, in phase 1 studies, the response rates in second line and beyond setting for extensive stage small cell were close to 35%. In the Trinity phase 2 trial, this response rate dropped to about 15%. So they looked at patients who expressed DLL3 at a high level, that's 50% or more cells, and they found that the response rates were better. So a phase 3, the Tahoe trial, was designed and reported this year, where patients who had failed platinum and had DLL high were randomized to either ROVA-T or topotecan in a 2-to-1 randomization. Primary endpoint, again, overall survival. Now, again, this was a negative study. Not only was it a negative study, the arm receiving ROVA-T actually did much worse. And they have significant toxicity with pleural effusions, pericardial effusions, edema, phototoxicity, so much so that the safety committee halted this trial. And the company developing ROVA-T has actually stopped development of this product. There's some silver lining as far as supportive care. The FDA has granted an approval to an IV CDK4/6 inhibitor, trilaciclib. Now, what the CDK4/6 inhibitors do, they prevent the cells from going from G1 phase to mitosis. So they prevent replication of cells, rendering them less sensitive to myelosuppression or cell death by chemotherapy. And this happens in fast dividing cells, but not so much in cancer cells. And in this trial, patients received upfront carboplatin with or without trilaciclib. It's a smaller trial. It's a phase 1b/2 trial. However, they were able to show that right here on the right-hand side, you can see patients receiving the trilaciclib, those that didn't receive the trilaciclib, and there was less incidence of severe neutropenia, febrile neutropenia, as well as use of growth factors or RBC transfusions, leading to the FDA approval. Even though the FDA has approved this, I don't think most of us are using it in real life. And there are many reasons for that. Obviously, an extra IV infusion is one of them. I'm not a radiation oncologist. However, I do find this is an important trial in radiotherapy. PCI, or prophylactic cranial irradiation, has been the standard for limited stage small cell lung cancer. However, it's more controversial in extensive stage small cell lung cancer. This trial, but one of the problems with PCI is long-term cognitive deficits. And this trial looked at an approach called hippocampal sparing or hippocampal avoidance, and randomized patients to hippocampal avoidance or not with PCI. Their outcome was to see if it improved cognitive function and if there was increased metastases in patients receiving hippocampal avoidance. This trial showed, and this was a Spanish trial, they showed that there was improvement in cognition in patients receiving hippocampal avoidance. However, there was no increase in incidence of brain metastases or overall survival. In all fairness, another trial run by the EORTC did not confirm these findings, also reported this year, and they showed that there was no improvement in cognitive decline, although the overall survival was the same in both trials. I think overall this is somewhat practice changing, and hippocampal avoidance is something that a lot of centers in the US are doing nowadays. I think this is the more interesting and enlightening part of the presentation, thinking about the future of small cell lung cancer. What we have accomplished in non-small cell lung cancer has been through understanding the biology of the disease, and that's kind of where we're headed to in small cell lung cancer. For the first thing is to realize that it's a heterogeneous disease, and the other thing is to look for biomarkers. Several biomarkers have been looked at, but none has proven to be of benefit. If you recall the CheckMate trial, right here you see the tail at the end of the curve. So there are some patients who seem to be benefiting. Same thing with the Keynote or the Caspian trial with tremelimumab. It seems like there's a subgroup of patients, but we have to identify that subgroup. Investigators have, from the CheckMate 331 trial, have looked at CPS score, which is PD-L1% or more or less, but there is no difference. Similarly, in the CheckMate 451, there was no improvement or prediction who's going to respond in patients who had high or low CPS to the PD-L1 or the PD-1 inhibitor. On the other hand, TMB, tumor mutation burden, seemed to predict patients who will benefit in the CheckMate 451 trial. Patients who had more than 13 mutations per megabase seemed to have more benefit from immunotherapy. Unfortunately, this was not replicated in other studies, although other studies used other cutoffs such as 10 mutations per megabase or 16 mutations per megabase. So this is not a definitive biomarker. More promising is a protein called Schlafen 11. Now, this is a DNA-RNA helicase, which leads to cell death in the presence of DNA damage. So if cells have Schlafen 11, they're sensitive to DNA damaging agents such as platinums or PARP inhibitors or topoisomerase. And this theory was tested in a small trial where patients were randomized in the second line setting to temozolomide with or without veliparib. Veliparib is a PARP inhibitor. And overall, this was a negative study. There was no difference whether patients got veliparib or not. But the investigators went back and looked at Schlafen 11 levels. Patients who had high Schlafen 11, here, right here in the blue, and got a PARP inhibitor seemed to do much better. This is the progression-free survival. Whereas if they did not get the PARP inhibitor, they didn't do so well. Similarly, in overall survival, look at the right-hand side right here. Patients receiving the veliparib and having high Schlafen 11 seem to benefit. So that's a potential biomarker I would look out for. There's an ongoing large trial looking at patients who have received platinum etoposide atezolizumab with or without talazoparib maintenance. And this is only in patients who are Schlafen 11 high. So this is something that I'm really interested in finding out the results in the future. The other thing that I mentioned is realizing that small cell lung cancer is not a homogeneous disease. Recently, we found out, and this was a publication last year, that there are some subgroups, and there are 4 subgroups based on expression of transcription factors. Investigators looked at it through RNA sequencing and IHC and identified 4 different subtypes, those expressing ASCL1, NEUROD1, POU2, F3, and YAP1. What we found out this year is from the group from MD Anderson is that there are 4 subtypes. However, the subtype YAP1 did not pan out. They looked at patients in their own institution and saw that the other subtypes were pretty much the same, SCLC A and P, but they found another subtype called the inflamed subtype. And as you can see right here on the right-hand side here, that the inflamed subtypes seem to do better than the others. More importantly, though, they went back and looked at the patients in the Empower 133 trial. They saw that the patients who had the signature for the inflamed subtype seemed to benefit from immunotherapy. Now, if you look on the left-hand side, these are patients who received atezolizumab. These are ones who didn't receive atezolizumab. And on the left-hand side, if you look at it, those which had the inflamed subtype seem to do better with atezolizumab, making it a potential biomarker for immunotherapy. Again, the other subtypes have their own targets, like the SCLC-A subtype expresses DLL3, so agents targeting DLL3 might be more important for those. They also express SHLOFN11, so PARP inhibitors might be a candidate treatment for that. As far as the N subtype, they express somatostatin receptors, and so the lutetium targeted therapies may be something that we can use for these patients. The SCLCP are sensitive also to PARP inhibitors, easy to remember. And just as we discussed, the inflamed subtypes may respond better to immunotherapies. Other future strategies include targeting DLL3, although not with the ADC Rova-T, but other drugs. Amgen is developing a bispecific T-cell engager. Now, this is a synthetic antibody where on the short arms, one of it attaches to DLL3, the other one attaches to CD3, bringing the T-cell in close proximity to the small cell lung cancer and leading to apoptosis. Another similar approach is with DLL3 CAR-T, chimeric antigen receptor T-cell therapy, and this is being developed. Both these studies are in very early phases right now, but they appear promising, and we'll have to wait to see the results in the future. At the end, I do want to remind you that small cell lung cancer is very strongly associated with smoking. We can develop all kinds of drugs. However, the key is to prevent this disease. And if we can encourage smoking cessation, I think that will go a much longer way as opposed to our interventions later on. Thank you very much, and I look forward to any questions.
Okay, hello. Thank you. Thank you, Dr. Noman. This was an excellent presentation telling us about advances in small lung cancer. I'm going to introduce our last speaker, last but not the least, Dr. Sundas Yahya, who is a clinical oncologist in Queen Elizabeth Hospital in Birmingham. She has graduated from Khyber Medical College, Peshawar, and she has got special interest in breast, lung, and skin cancers, immunotherapy, radiotherapy, and stereotactic ablative radiotherapy. She has been a co-investigator and author of many esteemed papers. Dr. Sunda, over to you.
Good morning and assalamu alaikum everyone. I'm Dr. Sundas Yahya, consultant clinical oncologist at University Hospitals Birmingham. I'm radiotherapy service lead. I want to thank Shaukat Khanum Cancer Symposium Scientific Committee for inviting me to talk on the role of stereotactic body radiotherapy in lung cancer. I will today in my session review what SABR actually means and how it has evolved in the last few years, reviewing the literature with regards to the role of peripheral, central, and ultracentral tumors, comparing SABR versus standard fractionation as well as surgery, identifying the patient selection criteria, which is the most important one, difficulties with the organs at risks, tolerances, and some practical points with regards to treatment delivery and verification. I will also share our follow-up schedule and some real case patient data. Stereotactic ablative body radiotherapy refers to precise radiotherapy of an image-defined extracranial lesion with the use of high radiation dose in a very small number of fractions. It is delivering high biologically equivalent dose using a hypofractionated regime, despite it being close proximity to critical structures. Comparing to the conventional radiotherapy, over the years, SABRE has potentially come out as a winner, particularly for better local control and improved survival. There is certainly some data coming out for the potential of better quality of life, and it has the advantage of continuing to be minimally invasive as well. When reviewing the literature, the first thing that we can see is that this treatment technique is not new. It has been evolved from the use of gamma knife, which initially Gaskell used in 1970s, but for the intracranial lesions. And the idea was to employ multiple radiation beams to the target lesion with very high precision and delivering an ablative dose. This instigated the use of hypofractionated regimes in different tumor sites, and in non-small cell lung cancer, it has certainly taken a major role. The treatment is prescribed to an isodose line covering the planning target volume, which means that the PTV or the ICRU dose reference point gets a very high dose within it, with sometimes the gradient showing doses as high as up to 180%. When we review the literature for stereotactic ablative radiotherapy, there is mostly retrospective data, and case matching becomes quite tricky. But recently we have had these two publications, which are randomized control trials. Most notable of this was the SPACE trial, which was the first clinical trial which compared the outcomes of stereotactic polyradiotherapy versus conventional fractionated radiotherapy regime. It randomized 102 patients to receive 66 gray in 3 fractions versus 70 gray over 35 fractions. It was a non-inferiority study, and it confirmed no difference in progression-free survival or overall survival among the group of patients, and the toxicity was comparable in both the arms. Subsequent to that, we had the publication of CHISEL trial, which was in phase 3 open label randomized controlled trial, which compared SABRE versus standard radiotherapy in 66 and 33 fractions of 50 gray and 20 fractions, depending on the institution's preference. The dose of SABRE was either 54 gray in 3 fractions or 48 gray in 12 fractions. The disadvantage of these studies is small patient number. The SABRE arm had 66 gray, whereas the standard radiotherapy arm had 35 patients in total. 20% of these patients progressed locally, but the results showed that the freedom from local treatment failure was improved in the SABRE group when compared with the standard radiotherapy group, with a hazard ratio of 0.32, with median time to local treatment failure was not reached in either of the group. The adverse events described were mostly dyspnea in 1 patient and grade 3 adverse events in 7 patients, mostly being cough, hypoxia, lung infection, weight loss, dyspnea, and fatigue. And it compared to 2 grade 3 events in 2 patients, which was chest pain in the standard treatment group. So the rate of adverse events was slightly higher in the SBRT arm as compared to the standard radiotherapy arm. When we reviewed the literature for the peripheral lung cancers, this was meta-analysis that was published and gives a very good overview of early stage non-small cell lung cancer, which were treated with SABRE. These patients, however, were medically inoperable, all including stage 1 and 2 cancers. Here you can see that the patients had an excellent outcome after SBRT, as the local control rate at 2 years, as well as the overall survival rates, were very good, being in the order of 95% being the local control rate and 57.6% being the overall survival rate. There has been a lot of hesitancy and caution used when we talk about the central and the ultracentral lesions. In the next couple of slides, I will explain how we define the peripheral, central and ultracentral lesions. But due to the very high toxicity rates reported, SBRT was not recommended as a treatment option, but latest publications and systematic reviews have shown acceptable toxicity as long as caution is exercised when picking up the patients and strict selection criteria being followed. There has been meta-analysis published which have reviewed as many as 500 plus central lung tumors. Although the difficulty remains that there is a lot of heterogeneity in planning, prescribing and delivery of SABR, as well as the common toxicity criteria that is used to define the toxicity being different as well. Therefore, direct comparison remains challenging. Despite all this, the local control rates within the central lesions still remain high in the order of 85%, whereas one study showed a lower 2-year overall survival of about 43%, whereas Bestjag et al. Has reported a more favorable overall survival of 72.7%. Ultracentral lesions, as you can see, there are 3 notable studies that I've quoted here, but the toxicity, as you can see in the third column, is 38%, with possible treatment-related death to be 21%, which is exceptionally high. This really dissuaded majority of the oncologists for prescribing SABR to ultracentral lesion, and therefore it is currently not recommended in majority of the centers, and we are still awaiting randomized data. There is a lot of debate ongoing, however, that the survival is not affected by the tumor location, and SABR can still achieve high local control with limited toxicity when appropriate fractionation schedules are used for central lesion. There has been a lot of interest, particularly when comparing SBRT versus surgical operability. A lot of retrospective data has been reviewed, but 3 randomized clinical trials that has shed some light on the comparison included the Roselle, the STARS, and the Z4099 studies. And all 3 of these studies compared the SBRT with lobectomy in patients that were deemed medically operable. So these were patients that you would have, in the best case scenario, offered surgery. Sadly, all 3 trials were closed prematurely due to poor accrual, and hence it was decided to do a pooled analysis of the Roselle and STAR trials. That showed decreased morbidity and no inferior overall survival and progression-free survival when SBRT was compared to lobectomy. The 3-year overall survival rate was 95% for SBRT versus 79% in the surgical group, although the hazard ratio was 0.14 and it crossed the confidence interval. The difficulty with both these trials was this small sample size, meaning that the data was not significantly reliable. However, we have had retrospective studies reported comparisons amongst similar group of patients treated with surgery or SBRT, and these have shown similar, if not inferior results with SBRT, even though most of the authors have reported unmatched baseline characteristics. As we all know that patients treated with surgery are usually more likely to be fit, young, healthier, and have more favorable lung function, whereas the patients that undergo SBRT are usually the opposite, more frail and with poor lung functions. The current guidelines suggest that patients with standard operative risk coded as a mortality rate of 1.5% and all stage 1 non-small cell lung cancers should be offered surgical option as the preferred treatment of choice, and SBRT is not currently recommended as an alternative to surgery outside of the clinical trial. This, however, changes if the standard operative risk reaches greater than 4.4% in patients who are older and with cardiac or pulmonary comorbidities, as well as poor functional status. Patient selection criteria is the most important when we discuss patients in the MDT for selection. I'm sure a majority of you would have seen this diagram. It is most commonly used when defining the location of the tumor, and that's how we define the tumor location to be peripheral, central, or ultracentral. There are several definitions, but I have picked up the ones that are most commonly used. The IASLC has defined peripheral lesion to be a non-central lesion, meaning that all tumors that are rising from the lung parenchyma at least 2 centimeters from the proximal or principal bronchial tree. Any lesion that falls within 2 centimeters of the proximal bronchial tree and mediastinal or pericardial, pleural, or brachial plexus is classed as a central lesion, whereas the Hylas trial defined the ultracentral zone to be any GTV that falls within 1 centimeter from the proximal bronchial tree, overlapping the trachea or main bronchi, or overlapping the mediastinum. Talking a bit about the practical aspects of SABRE or SBRT planning, the treatment volumes are slightly different than what we see in conventional planning. The organs at risks should be contoured more than or equal to 2 centimeters superiorly and inferiorly for the PTV, for the coplanar techniques, and within 15 centimeters of the PTV if non-coplanar techniques are used. By non-coplanar technique, I mean the cyberknife treatments where the beam of radiotherapy could enter and exit from any side. The concept of mobile GTV is standard for SBRT. Majority of the centers would continue to use a 4D-CT scanning, and then the MGTV, which is the mobile GTV, is marked up, which is equivalent to the CTV, which is further grown to PTV depending on departmental protocols. Tumor motion is the hallmark of lung SBRT, and there has been several attempts made to encompass the motion and restrict the motion as well. There are several tracking devices, and a few strategies are used to deal with the mobile targets of more than 1 centimeter. These include abdominal compression, respiratory gating, coached respiration or active breathing control device, which allows the patient to hold the breath for up to 20 seconds. They are coached for with these devices and have to have sufficient respiratory reserve to be able to uptake these techniques. In some cases, you have to employ more than one technique, i.e. the abdominal compression or active breathing control, to limit the mobile GTV motion. The body contour should also be contoured wherever the beam traverses it. It is quite important that when we are outlining, that the skin should be inspected to ensure that the beams do not overlap, and because it can produce excessive skin dose, especially when there is a skin fold. The dose fractionation is picked up depending upon the location of the tumor. For the PTVs that are not abutting the chest wall, the most commonly dose fractionation is 54 gray in 3 fractions, or at least that is the most commonly used fractionation at our center. For any PTV that is abutting or overlapping the chest wall, the most commonly used fractionation is 50 to 55 gray in 5 fractions. And any MGTVs that are abutting or within the central zone but outside the ultracentral zone, a fractionation schedule of either 48 gray in 4 fractions or 7.5 gray in 8 fractions. Sorry, times 8 fractions is employed. When assessing the plans and outlining the organs at risk, as I've said before, any OARs which are traversed by a treatment beam should be contoured. They are not limited to the ones that I have just outlined here, but the most commonly used OAR within the thoracic plan assessment forms include the brachial plexus, the heart, the trachea, and the bronchi, both lungs, chest wall, and the great vessels. All centers would have these plan assessment forms for the 3, 5, or 8 fractions, where you have either optimal or mandatory constraints to meet. The endpoint obviously is the toxicity, and the aim is to keep it to the minimum. Treatment delivery can be quite complex and challenging, particularly during the infancy of this technique at any center. Day 0 verification is very important, which actually means that we check that the planned treatment is deliverable, that the patient can comfortably maintain his or her position, and the breathing in time with the metronome is without any fault. Using the cone beam CT scans, we match according to the standard treatment protocols, and we check the patient's setup, and any inconsistency of matching has to be repeated. Talking about the follow-up schedule, the recommended follow-up is a surveillance scan at 3 months to assess the treatment response. This is a patient of mine whom I only saw last week for a left lower lobe spiculated mass. He was treated to a dose of 55 gray in 5 fractions in April 2021. He did, in the post-treatment phase, 4 to 6 weeks later, required a couple of courses of antibiotics and steroids, which is quite evident from his September 2021 CT scan, which reassuringly showed reduction in the size of the left lower lobe mass, but with surrounding band of scarring and inflammation, as well as consolidation, which remains quite common. So the follow-up schedule thereafter remains to be annual surveillance if there are no concerns, but otherwise it is up to the clinician to decide whether they would choose to do surveillance at 3 months or 6 months, depending upon patient's symptoms and the level of pneumonitis. So in conclusion, advanced radiotherapy techniques such as SABR has shown improved local control and overall survival, and established as an important treatment strategy in the management of non-small cell lung cancer. It is very important to familiarize the indications and the treatment delivery for SABR. In the UK, currently, we have got a SABR rollout program run by NHS England, and 43 out of the 50 trusts are currently able to deliver SABR, with the aim to extend the rollout for metachronous oligometastatic disease to all centres by December 2021. I would end my talk with, again, extending my thanks for listening, and I'm happy to take any questions should you have, and I'm going to leave you with this picture on.
Okay, thank you, Dr. Sundas, for an excellent talk. Now the floor is open for question and answers. So if you have any questions, please, to any of the speakers, please put your questions forward.
So maybe I can start my question with Dr. Mohammed Tufail. So Dr. Tufail, you've just shown us the optimal lung cancer pathway and how you've optimized it and a quicker access to these patients. So what do you think about the waiting time in radiotherapy and on chemotherapy? So have you incorporated those waiting times into the pathway as well? So are these like the slots reserved for these patients for chemo and radiation, or that is not part of the pathway?
I think that is a great question. And a bit a stingy one for us, I mean, with our pathway, and it depends from unit to unit. But if you look at the National Optimal Lung Cancer Pathway guidelines, once you have made the diagnosis of lung cancer and all the molecular markers and everything is available, diagnostic work is done, patient has to be seen by oncologists within 3 working days. So that is the target. I mean, our recent audit of our department has shown that we are not achieving that, unfortunately. I mean, our patients are seen 10 to 12 days after the diagnosis. So that is the work in progress. And obviously, there are lots of resources issues, etc. As you know, NHS does not have bottomless pot of money, and we are resources constrained, staffing issues, etc. So that's true. So we have speeded up our front end of the pathway, diagnostic pathway, but we had challenges on the treatment end, and we are working on it.
Okay, thank you. So Sundas, we have a question from our audience regarding the use of calypso markers and for measuring the intrafractional variation in lung cancer. So do you have any experience or any comments about those?
So we don't use it very much in, obviously, thoracic radiotherapy. We use it more for either prostate brachytherapy or, if you're using CyberKnife technique, it's not used very much on the Linac-based treatment, to be honest. We have, quite good gating techniques. So the markers itself, and more recently, we have used sort of, laser techniques that have been very good. So not in the thoracic radiotherapy, but yes, in other tumor sites, such as lymph nodes, bones, and areas that you would want to track, not on the Linac, but on the CyberKnife machine. Yes, you do.
Okay, thank you. Dr. Fateh, do you have any questions?
Okay, there's a question from one of the audience as well, which says the role of tumor mutational burden and its implication, especially in regards to lung adenocarcinoma, which are negative for PD-L1. I think Dr. Hamza.
Yeah, thank you. It's a good question. I think there was some clinical trials trying to delineate if there's significant prediction from tumor burden. And I think, and during the phase 1 and phase 2 of the study, there was some hints that might be beneficial. But later on, it was not of a great significance at the phase 3 trial. So at this point, as of today, I don't think tumor burden would affect your, I would say, a choice of a treatment. It's going to be chemotherapy plus immunotherapy, whether to use single immunotherapy or doublet. That would depend on your patient, their age, their functional status, performance status, and the volume of disease. And at the same time, also if you have fund for all of those together. But I will not depend a lot on the tumor burden. Plus, we don't test a lot for them in their clinical practice. Thank you.
Okay. Yeah.
I have a question for Dr. Bennett as well. Hello, Dr. Bennett. Thank you for joining us at this early time in the morning. My question is, how did you train your nurses to deal with, like, as you said, you diagnose the cases only on chest X-ray and then expedite it to CT scan, not involving a doctor in the first instance?
So Fatullah, thank you. It's a direct pathway. So essentially the chest X-ray is recognized to be abnormal, or we have criteria that take them to direct to CT. And then at the point of them having the CT, the nurses go down and take a brief targeted history, which is partly protocolized, but also they have a lot of experience. So they know which questions to ask, and they make an assessment of things such as WHO performance score and an assessment of clinical frailty, so that we have an idea of what their performance is like, and therefore they will also then take them through the possibility of the diagnosis of cancer. And so therefore we can often then phone them subsequent to reviewing the CT scan to initiate the diagnostic pathway. So the nurses have a lot of experience. They have a targeted history taking pathway, and the criteria for going straight from chest X-ray to CT is predetermined. Does that help?
Yeah, thank you. We have another question from the audience. So they basically was aimed at Dr. Noman. So they want to ask about the role of adjuvant immunotherapy and whether it looks promising or not. I think the others can answer.
Yeah, maybe Sundar or Dr. Hamza can take over this question.
Yeah, so I think there's a lot of ongoing clinical trials at this moment in non-small cell lung cancer mainly for in the adjuvant and new adjuvant settings. So there is a few of these trials for Pembro as PD-1 inhibitors, for also atezolizumab, Dorba, and there I think will be soon in the coming month or so publication for the Dorba results from the clinical trial BR31. There is some clinical improvement. I think there will be a new approval for adjuvant and a new adjuvant. But as of today, I don't think we have the final data from those studies. And they are working very collaboratively with the surgeons in the new adjuvant settings. There is a lot of talk from phase 1 and phase 2 about pathological complete responses, about other also biomarkers that you might achieve. But other than out of the clinical trials, I don't think we have any these days.
Yeah, I mean, we've got the same practice within the UK as well. In the neoadjuvant setting, we haven't got anything, any different practice outside of the clinical trial. But additionally as well, in the neoadjuvant and the adjuvant setting, there is more and more trials coming up, and we've got some at our centers ongoing as well that has combined adjuvant treatment or even, combined concurrent chemoradiotherapy with immunotherapy. So, yeah. So I think it's really good news for the patients. I mean, particularly the lung cancer patients, it's evolved massively. And, we've got patients living much longer. I think one of the points that I just wanted to highlight, if we are okay with time, is that, we have actually deviated from, some of the pathways during the COVID pandemic as well. In the last 2 years, we've actually learned a lot. Sadly, there were situations where patients couldn't follow the pathway, and as clinicians, you had to offer them the best possible. So I just want to call one of my patients whom I just could not deliver, what I intended to deliver, and he couldn't be operated, but he only had 36 gray in 12 fractions of radiotherapy. And once, our thoracic surgeons got hold of the ITU beds and on, he got operated, and he actually had complete pathological response. So, radiotherapy does work wonders. Please make friends with your clinical oncology colleagues, use it. But then equally, we were also in situations where If you have got a very good performance status, 0 to 1 patient, and they had stage 4 disease with no or limited involvement of the lymph nodes, and you've used 2 years of pembrolizumab, what do you do then? So we have carefully selected a few patients more recently, and they have actually gone down the surgical pathway and have been operated with complete pathological response. So, again, it is something that is not standard practice, but something that, clinicians and in multidisciplinary teams, should be identifying patients like these.
Yeah, so Sundus and Hamza, so regarding oligoprogression, if this patient is on systemic treatment, whether it is immunotherapy or ALK or EGFR inhibitors, and we just get an oligoprogression, what is your take on that? And how do you deal with that situation? Do you change or switch the systemic therapy if we can even target the localized oligoprogressive disease?
Yeah, Sundus, would you like to start?
Yeah, so within UK, we are not commissioned to treat oligoprogression outside of the clinical trial, but we do have HALT trial, which is ongoing, which is basically patients involving targeted mutations. And if they have oligoprogression, you can randomize them to the trial and offer them SABR. And in addition, we have a SARON trial as well, which is again patients who have had up to 3 areas of oligometastases. You can randomize them to SABR arm. That's still open as well. So outside of the clinical trial, we're not doing it. But yes, again, it is certainly an option. And, unfortunately, we are not commissioned to do it, but, there is more and more data coming out for it.
I agree with Sundus, but also we should differentiate if patient on IO or checkpoint inhibitors, any one of them, we usually look at the site of progression. If they are the same original lesions, and these are after a few months or a few cycles, there still should be some sort of pseudo progression that happens from the inflammatory response of this immunotherapy. If they are the same lesions, you should wait. You should continue with immunotherapy till you see what's going on. But if there is a new lesions, or there is sometimes those rare hyper progression, you should just switch the treatment right away. For TKI, it's a little bit different. If we're talking about oligoprogression in the brain, then you can control the brain, whether whole brain or SPRTs or whatever you do with what you have access for. Then you repeat the stagings. If there is nothing outside growing, you continue with same treatment. But if there is worsening areas outside, there is 2 ways to go, whether you switch right away, or if you are working in a university hospital, you might consider doing another biopsy or having a liquid biopsy to investigate what are the resistant mutations that you have. And one important message with TKI I would like to have here, we've seen a lot of transformation to small cell, mainly in EGFR mutated patients. You're going to be treating them, responding nicely within few months or a few weeks, they will be in the emerge with different pictures. So keep it in your mind for the small cell transformation.
Okay, thank you very much. I think we have no more questions. Dr. Fateh, do you have any from your side?
No, thank you very much.
May I ask you one question, Fadullah and Dabinder? So, given that lung cancer screening is coming up in Western world, low dose CT scan, and it is proved in different trials. Coming back to the Pakistani settings, where there is no easy accessibility to do even chest X-rays. People use cough suppressants for lung cancer. I'm sure patients must be coming.
Anti-tuberculous as well. So
and anti-tuberculous, obviously, and wrongly treated, everything treated as TB to start with. Is there any role of, I know the chest X-rays screening has not worked in the Western world, but is there any role of smoking cessation and to start with chest X-ray screening in Pakistani setting? Some trial setup or anything so that we can pick up these cancers early in Pakistan, just with chest X-ray and inappropriate patients.
Yep. So recently we've started a lot of awareness campaigns regarding smoking cessation from schools to college levels. And there are many different public sectors and even in government sectors, the hospitals are involved in awareness for smoking cessation. But as far as the screening program is concerned, you are aware that there is no screening program. We normally get a lot of lung cancer patients in very advanced stage disease. We've hardly seen stage 1 in last 4 or 5 years. So I think that's a good way to start with awareness first, and maybe a low cost screening program in a trial form to get the idea about the load and how people will take this, and then we can take it from there.
I think I would second Dr. Tabinder's answer. Basically, even in KPK, the part of the country that we are in, it's even more remote than Lahore. So patients that we see are like in stage 3 or 4 by the time they present to us in the walk-in clinic anyways. So I think this is a very good suggestion, but it needs to come from the top. So maybe if you tell Imran Khan this.
Absolutely. The lot can be done.
Yeah.
Thank you very much. I would like to thank all the panelists for taking their time out, especially with the huge difference in timings and this time zones. And it was a wonderful and very informative session. Thank you so much.
Thank you all of you. Thank you.
Thank you.